Confidently lead AI integration in your practice with practical, clinically focused strategies. Join RSNA in Barcelona, Spain, October 16th through 17th for Radiology Reimagined, Advancing Clinical Practice Through AI Innovation. This 2-day course delivers case-based learning, expert-led Q&A, and real-world implementation guidance to help you evaluate and apply AI. Register today at rsna.org/Barcelona.
Hi, everyone. Welcome back to another RSNA RadioGraphics podcast. My name is Sophia O'Brien, one of your hosts for today. I'm a breast and nuclear radiologist at the University of Pennsylvania. I'm also one of the associate program directors for the Penn Diagnostic Radiology Residency and co-director of our resident clinical educator track.
And I am your other host, Austin Pantel. I am a nuclear radiologist at the Hospital of the University of Pennsylvania and the program director for the Penn Nuclear Radiology Fellowship. I'm also a colleague of Dr. O'Brien's. And lastly, I'm also a member of the SNMMI PET Center of Excellence.
Today we'll be discussing our radiographics article entitled 18F Fluoroestradiol, Current Applications and Future Directions. 18F fluoroestradiol, also known as FES, is a PET radiotracer and an analog of estrogen which binds to the estrogen receptor. FES was FDA approved in 2020 for imaging in patients with metastatic or recurrent ER-positive breast cancer.
Our radiographics review article on FES was co-authored by our excellent colleagues at Penn, Dr. Christine Edmonds and Dr. David Mankoff, as well as two prior Penn trainees who have now moved on to bigger and better things. Dr. Shannon Lamzo is now an attending at Morristown Medical Center, practicing both nuclear radiology and breast imaging, and Joe Weeks is an attending at Cornell, practicing interventional radiology and nuclear medicine. Our paper was published in 2023 and gave an overview of when and how to utilize FES PET-CT to improve patient care, which we will review with you during this podcast. Of course, since that time, there have been additional developments, and we will also touch on that here.
Yes, Austin. Nuclear medicine is a quickly changing field, and additional clinical updates have been published since our radiographics article, namely the Society of Nuclear Medicine and Molecular Imaging, or SNMMI, Appropriate Use Guidelines in 2023, and an update to the National Cancer Center Network Clinical Guidelines in 2024, which we will also review. So let's get started. All right, Austin, let's first give our listeners a little primer on breast cancer and the importance of the hormone receptor profile.
Absolutely. As you know, breast cancer is the most commonly diagnosed cancer in women worldwide, with 1 in 8 women diagnosed in their lifetime. In the United States, breast cancer is the second leading cause of cancer death in women. Sadly, I'm sure we all know someone who has been affected by breast cancer. The NCCN guidelines recommend receptor profile testing in all patients with primary or recurrent breast cancer. The receptor profile is currently developed by immunohistochemistry, abbreviated IHC, which is obtained on biopsy samples, which assesses the cancer cell's expression of 3 receptors: the estrogen receptor, as we may call ER, the progesterone receptor, abbreviated PR, and the ERB2 receptor tyrosine kinase 2, formerly called HER2.
Approximately 80% of all newly diagnosed breast cancers are hormone receptor positive, meaning ER and/or PR positive. Patients with hormone receptor positive breast cancer have the best overall prognosis. Part of that improved prognosis is due to the use of ER-targeted therapies, also known as endocrine therapy or hormone therapy, in patients with ER-positive breast cancer. These include aromatase inhibitors like anastrozole that work peripherally, selective ER modulators like tamoxifen, and selective ER downregulators like fulvestrant. I'm sure anyone that's been on a breast tumor board has heard these treatments mentioned. They are truly the mainstay of therapy.
The hormone profile of cancer is determined by immunohistochemical staining of 1 or more biopsy sites, usually the primary breast cancer, and in the case of metastatic disease, a site of metastasis. So, in someone with breast cancer, the hormone profile is not assessed at every site of disease. Obviously, getting actual tumor tissue is hard and comes with inherent risk. For example, we can't biopsy every site of disease, nor every site of disease over time. And some sites of disease, such as those deep in the body or next to critical structures, often cannot be accessed at all safely. Also, there can be receptor expression heterogeneity between the primary cancer and metastatic sites of disease, which is extremely important to know. If, for instance, a patient has ER-positive breast cancer, but sites of metastases do not express the estrogen receptor or expressing non-functional estrogen receptor, which cannot bind to endocrine therapy, then those sites of disease are not being appropriately treated with ER-targeted medications.
Additionally, osseous metastases, which are common in patients with metastatic ER-positive breast cancer, can have a relatively high false negative rate on ER testing by immunohistochemistry due to the way the tissue is prepared, meaning the site of osseous disease can be truly ER positive, but due to the processing, the bone biopsy sample erroneously looks like the site is ER negative.
Yes, Sophie. And FES has benefits in all of these tests that we just mentioned. Truly, FES is a powerful tool and a needed tool and a complement to biopsy in patients with ER positive breast cancer. FES PET can assess the functional estrogen receptor expression at all sites of disease, supplementing information from tissue sampling, directing future biopsies, and informing treatment management decisions. Okay, Sophie, let's review the indications for FES PET CT.
We wrote the radiographics article before the SNMMI appropriate use criteria had been published, and in our article we discussed general clinical uses for FES PET CT, namely to select a biopsy target, to clarify FDG avid disease, to assess the burden of ER-positive disease, and to identify spatial and/or temporal ER heterogeneity. These can be better understood through the subsequently published appropriate use criteria, so we'll use those to scaffold our podcast. For those interested, we highly recommend reading the appropriate use document yourself. It's really well written and engaging. A summary is available in the Journal of Nuclear Medicine, and the actual appropriate use criteria are available on the SNMM website, easily found through a Google search. Okay, the first SNMMI appropriate use criteria is to assess ER status in lesions that are difficult to biopsy or when biopsy is non-diagnostic. This is also a useful indication when a patient has an ER-positive primary breast cancer but ER-negative bony metastases by immunohistochemistry, since, as we discussed, the IHC can be falsely negative in those patients. FES PET CT is very helpful to see if a non-diagnostic biopsy or a site of disease that is unable to be biopsied can bind to FES. Since FES binds to the estrogen receptor, FES avidity at sites of disease confirms the presence of the estrogen receptor at those sites, meaning there's ER-positive metastatic disease there. In fact, FES binding is very specific. Abnormal FES uptake almost always indicates ER-positive metastases. Unlike FDG, FES does not bind to inflammatory or degenerative changes. Reactive bone marrow from medications will not demonstrate abnormally high FES uptake like it does with FDG. Our article has multiple examples of FES positive and negative bone disease and examples of clarifying disease burden.
We've mentioned that FES binding in abnormal sites is specific for ER-positive metastatic disease. But first, let's review the normal biodistribution of FES so our listeners can identify these actual abnormal sites. So, like other radiotracers, FES is injected into an arm vein, and FES in particular, because it's a relatively sticky tracer, can be seen along that injected vein. So, be careful about what side you're injecting in depending on where you're actually looking. So FES binds their estrogen receptor in the uterus, but there is not much binding in the breasts or ovaries. As an estrogen analog, FES is a steroid and is rapidly removed from the circulation by the liver, metabolized, and excreted into the biliary system. It then travels to the small bowel, where it is efficiently reabsorbed back into the bloodstream, meaning there is essentially no uptake in the large bowel. Then the kidneys excrete it. So the normal biodistribution includes the injected vein, the uterus, and organs of metabolism and excretion, namely the liver, biliary system, small bowel, kidneys, ureters, and bladder.
Now, there's also very low level estrogen receptor expression in the lungs, so we can see mild FES uptake in areas of atelectasis. But again, we will not see FES uptake at inflammatory or degenerative sites. So uptake in the bones, nodes, lung nodules, etc. almost certainly reflect ER-positive metastatic disease, with some very few exceptions.
Yes, Sophie. I think this is a great point that is surprising to many. FES images the estrogen receptor, which is very specific and not widely expressed in the body. This, of course, is very different than FDG, which is plagued by nonspecific uptake, as glucose metabolism is quite ubiquitous throughout the body. And anyone that reads an FDG PET scan clearly knows this. So, in some ways, reading an FES scan can be thought of as more straightforward than reading an FDG scan.
I agree, but we have to remember that since the liver so efficiently removes FES from the circulation, the positive SUVs on FES PET CTs are much, much lower than those for other tracers like FDG, PSMA, or DOTA tape. A positive finding on FES PET CT is simply FES uptake higher than local background. And oftentimes we see SUVs at true sites of ER-positive disease as low as 2 or 3 or even less. In fact, an SUV of 1.5 or higher has been used by the literature to identify sites of ER-positive breast cancer which will respond to endocrine therapy. I tell my trainees to remember to use their FES eyes when reading these scans because sites of very mild uptake that we would often scroll right past as mild inflammation or even presume physiologic uptake with other tracers will truly reflect sites of ER-positive disease with FES. This is especially true with anatomically normal appearing lymph nodes and low but true FES uptake. Abnormal FES uptake in a lymph node, even a tiny one, is very suspicious for ER-positive metastasis. Our article has a case of a patient with multiple abnormally FDG-avid lymph nodes in her axilla, internal mammary, and pelvic chains, too many to biopsy all sites. A subsequent FES PET CT demonstrated abnormal FES uptake in the axilla and internal mammary nodes, confirming ER-positive metastatic breast cancer at those sites, and FES negative presumed inflammatory pelvic nodes, which were confirmed benign on subsequent imaging and clinical follow-up.
Yes, that was a great case. And there's many great cases in that article that we wrote. So now let's get back to the appropriate use criteria. So we just discussed the first. Let's discuss the second, which is to detect ER status when other imaging tests are equivocal or suggestive of metastases. This indication is very useful when there are indeterminate findings on other imaging studies, such as MRI or FDG PET CT. Again, since FES binding is specific for ER-positive disease, identifying FES binding at an indeterminate site from another scan confirms that the site is indeed ER-positive disease. Alternatively, lack of FES binding at a site, which was deemed indeterminate or suspicious for disease, may reflect ER-negative disease at that site or may indicate that there is no disease there at all. Again, FES is specific for the estrogen receptor, not cancer in general. FES PET CT can therefore be used to evaluate indeterminate findings and identify optimal sites to biopsy if needed. If a patient with ER-positive metastatic breast cancer has sites of ER-negative disease, that is very important to know and to prove because it will change the patient's treatment course. And FES can help identify such sites for confirmatory biopsy. Our article has examples of FES PET CT used to clarify indeterminate FDG-avid findings in lymph nodes, bones, lungs, and a reconstructed breast. We have a very great case of a very mildly avid contralateral axillary lymph node in a patient with newly diagnosed invasive lobular carcinoma. Further characterization with FES PET identified mildly but truly FES-avid contralateral axillary and bilateral cervical lymph nodes, which looks completely normal on FDG. Subsequent biopsies confirm metastatic ILC at these sites, which were only identified on FES. In fact, staging invasive lobular cancer is deemed as may be appropriate by the SNMMI guidelines, and we identified this as a potential future direction in our article. In fact, since that paper, the NCCN has updated its guidelines and now recommends considering the use of FES PET CT for systemic staging of recurrent or stage 4 patients with lobular histology.
Excellent. We're going to keep going with our appropriate use criteria. The third and fourth appropriate use criteria for FES PET CT are at initial diagnosis of metastatic disease or at progression of metastatic disease for consideration of first or next line endocrine therapy. Studies have shown that patients with ER-positive metastatic breast cancer by immunohistochemistry but with negative FES PET CT do not respond well to endocrine therapy. And we think this is because their sites of disease are not able to bind to estrogen or its analogs. Confirming FES avidity and therefore confirming functional ER binding at all sites of disease confirms that a patient is a good candidate for endocrine therapy. And identifying disease heterogeneity on FES PET CT allows for tailored treatment decisions for our patients. Disease heterogeneity is certainly a hot topic of research, and we will definitely hear more about this for years to come.
Yes. So we like to think of FES PET as a great tool in patients with ER-positive metastatic or recurrent breast cancer for problem solving and for whole body disease characterization. But like all tests, FES PET CT has its limitations. Most importantly, since the liver so efficiently metabolizes the tracer, background liver uptake is very high and limits the use of FES to assess liver lesions. We, in our practice, have seen liver metastases which have higher uptake than background liver, some have lower uptake, and some which are totally invisible against background liver, especially for small lesions. And we have multiple examples of this in our radiographics article. So, if you see an abnormal finding in the liver on FES PET, you should recommend further characterization with liver MRI. And remember, FES PET CT cannot be used to characterize or confirm liver metastases seen by other imaging.
Exactly. There are also false positive findings, though few. We can see abnormal FES uptake in areas of post radiation pulmonary changes, we think because radiation to the lungs causes leaky vessels there temporarily. We have a case of this in our article. We also have subsequently identified that the lymph nodes draining areas of FES uptake in radiated lungs can also show FES uptake. This is not from FES binding to an estrogen receptor in those nodes because those nodes don't have estrogen receptors, they are benign, but simply due to the drainage of the free FES radiotracer from the lungs into those nodes. This is a tricky false positive. We published this case in the Journal of Nuclear Medicine.
Additionally, sites of disease which are very tiny or which have few estrogen receptors may appear negative on FES. This, of course, is not limited to FES PET, but true of all radiotracers that we image on PET. Lesions that are too small may simply not be seen. And other sites of ER-positive metastatic disease, such as from uterine cancer, can also appear positive. So remember, we are imaging the estrogen receptor.
Lastly, patient preparation for FES PET-CT is easy, but patient choice needs to be thoughtful. FES PET-CT can be performed in men and women pre or post menopause. The amount of estrogen circulating in the patient's body will not affect the images. FES has not been tested in women who are pregnant or lactating or in children. FES PET-CT cannot be performed in patients who are currently or who were recently on an estrogen blocking medication. So this is a big thing to check when we're protocoling these studies. Aromatase inhibitors, which reduce the amount of circulating estrogen but do not interact with or block the ER itself, are okay. But estrogen blockers like tamoxifen or fulvestrant will block FES's ability to bind to the ER, so we won't know if disease is simply blocked or treated or if sites are now ER negative. Unfortunately, the washout period for these drugs is quite long, 8 weeks for tamoxifen and 28 weeks for fulvestrant, so it's recommended to image patients with FES PET-CT before initiation of these treatments to confirm homogeneously ER-positive metastatic disease, which is likely to respond to those therapies. We show an example of how FDG PET-CT can be used to identify sites of disease. FES PET-CT can confirm ER positivity, and then FDG PET-CT can be used for treatment response assessment after an ER blocking agent is initiated.
Agreed. And I think that last point is a great point and worth taking a second to discuss. FES cannot bind to the estrogen receptor if a drug is already bound to the receptor. So it's very important to check medications prior to protocoling the study. At Penn, we have a box that the protocoling physician needs to check prior to the study being protocoled that ensures that we take a second look at the medications that the patient is on. Also, we recommend confirming proper tracer targeting by ensuring the uterus demonstrates normal uptake, serving as a positive control in a patient with a uterus. It's truly a shame when a patient goes through all the effort to have an FES scan that in the end it is uninterpretable.
Okay, so that was a whirlwind tour through the land of FES. Thank you, Dr. Austin Pantel, for joining me on this podcast, and thanks again to Doctors Edmonds, Lanzo, Weeks, and Mankoff for writing the paper with us.
Well, thank you, Dr. O'Brien, for taking the lead on this RSNA submission and the subsequent radiographics articles.
And dear listeners, thank you for joining us. Just a reminder to please rate, review, and subscribe to the RadioGraphics podcast. Your interaction with the podcast helps others find episodes and expands the RadioGraphics audience.
And please check out the RadioGraphics website, where you will find our article as well as many, many other excellent articles to support your learning and your practice.
See you on the next podcast.